What would a trip be to ASCO without a visit from Elizabeth Mittendorf from MD Anderson Cancer Center? And thank you for being back, and thank you for your work in this past year. You have more to report.
Right, and thank you for having me back. I appreciate the opportunity. A year ago, I think you and I chatted about an interim analysis on this peptide vaccine trial. So it's a phase 2 study investigating an MHC class 2 vaccine. That the big news last year was really that this is safe and it appears to stimulate an appropriate immune response. And we're beginning to see some benefit clinically from it. And now this year we're able to present the primary analysis. So the primary analysis was triggered after a certain number of patients who'd been enrolled on the trial had recurred. And what we're reporting is that I think this trial accomplished pretty much everything you'd want a phase 2 trial to do. It showed again that the vaccine is safe. It demonstrated that we have the appropriate dose identified. And importantly, I think it's identified what will be the appropriate patient population to consider for further trials investigating this agent. And what I mean by that is the trial enrolled patients with any degree of HER2 expression, so 1+, 2+, 3+. And overall, although there was no benefit to vaccine, it appears that if we look, and we did this through a pre-specified subset analysis, for those patients who have the low HER2 expression, that's where we're seeing the benefit. It's about a 40% relative risk reduction for the HER2 negative patients. And if you go and drill down even further and look at the truly triple negative, so not only HER2 negative, but hormone receptor negative, we're showing about a 60% relative risk reduction. Now, I would caution that this, by the time you get down to that subset analyses, although planned, they're smaller numbers of patients, but in my mind, it really does illustrate that the HER2 negative patients, perhaps really the triple negatives, are the group that we should be targeting for clinical trials going forward.
So you feel in this past year like you've got much more of a foundation now for going forward.
Clearly, we have more of a foundation. If nothing else, the trial has, which I believe was a well-designed trial, it was well randomized, well controlled, has hit the primary analysis. And so I think that is data that we can take to groups to potentially get some interest in a phase 3 study.
In a personal way, Beth, the diagnosis of breast cancer for a patient can be devastating.
Right.
And when you think you're starting to get a handle on it, or maybe you do, when a relapse sets in,
right,
it's
devastating. Yeah, and I see that in my practice. And to be honest, that's one of the reasons that I've had so much enthusiasm for this vaccine approach. I think we've discussed before that this is not a vaccine we're giving necessarily to treat the known cancer. We're treating the known cancer with all of the standard of care therapy that we've worked so many years to establish, so surgery, chemotherapy, and when indicated radiation. We're giving the vaccine to prevent recurrence, so to prevent that scenario that you're describing. And so we're giving it to patients at a time when they're told, we're done, go home, watch and wait, we'll see you back in 3 months or 6 months. And so I'm able in my office, and this is what I always say to patients considering the vaccine trials, we're done with your standard therapy, we have a vaccine, it may reduce your risk of recurrence, and the cost is going to be coming in once a month for 6 months, get the injection, which will cause a little bit of redness and maybe some itching at the injection site. A few patients have these transient flu-like symptoms. They last about 4 hours. And for that cost, we may reduce your risk of recurrence. And one nice thing now about this trial is I can more clearly tell the patients what I think that reduction will be. So for the HER2 negative patients, I can tell them I think we're going to reduce your risk by 40%. And for the triple negative, I think we're going to reduce your risk by potentially 60%. Of course, I always tell them that these results need to be confirmed in larger trials, but again, we're not replacing anything we know works, and there's really no toxicity. So there's a lot of enthusiasm from the patients.
Hard to figure out who'd be more excited, you or your patients.
I don't know that many are more excited than I am, but I like to think that we can generate that enthusiasm in the folks.
Very good. Thank you for the great work you're doing.
Thank you.
Get back to it, and we'll see you again soon.
All right, thanks very much.